All right, good morning. We're gonna get started. Um, I'm Francois Trappe. I'm the pediatric surgeon here now. Welcome everybody. Um, Dr. Kemp asked me to talk about CDH as the first of a couple ped surgery topics we're gonna discuss over the next, 2 months or so, Phil? CDH is an interesting disease in that the surgery is, at least in principle, is not all that complicated. You're just kind of closing a hole, but it's a complicated disease because of all the sort of physiologic derangements that these babies have. And so we'll just kind of walk through these pretty slow and give you a sort of a foundation for it. People spend their whole career on this disease. And so we'll talk about a couple of things. I added a couple of slides for those of you that were here yesterday on FETO, and we'll see if we can get some of these FETO videos to work. There's a good supplement to the New England Journal article about it that shows how you place a balloon and different things. So we'll talk about the epidemiology, embryology, pathophysiology of disease. We'll talk about fetal assessment. That's really sort of one of the big emerging areas in diaphragm hernia, not only fetal assessment, but central fetal therapy, the initial assessment and resuscitation of these babies, some repair strategies, and then some long-term outcomes. So the diaphragm, we don't know exactly how any of this forms. If you go back and look, I've written a couple of review articles and looked at sort of the introduction statement. So a lot of these chapters will sort of reiterate the same things about development. Oh yeah, things develop at 4 to 6 weeks, blah, 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 blah. There are these folds, whatever. And if you go and look for the source material, it's written by German dudes in like the 1700s. And there's just not a whole lot of funding to update these things. There's a little bit more molecular embryology type stuff going on, but in general, the foundation of all this stuff is very, very old and could use updating. We do know, and we'll talk a little bit about it in some upcoming slides, but there's a simultaneous disruption in diaphragm and pulmonary development, as well as development of the pulmonary vascular tree, and we don't understand those interactions. The buzzwords for tests really are failure of closure of the pleuroperitoneal canal. The pleuroperitoneal canal closing involves 3 key structures: septum transversum centrally, which contributes to the pericardial floor eventually, and the central tendon of the diaphragm, the pleuroperitoneal folds, and the posthepatic mesenchymal plate. So closure of all those separates the thoracic cavity from the peritoneal cavity. There's no consistently identified teratogenic or environmental factors throughout the studies. So if anybody wants to figure that out, that's pretty ripe area. These are the 2 most common defects. The Morgagni defect is centrally located in the anterior, and then the Botchelek defect, which is most common, you can remember back into the left, is the most common type. Left-sided CDH is about 90%, right side about 10% of the non-Morgagni defects. Defect classification. So we'll talk a little bit about prenatal measurements. The classification is extremely important, but as my last bullet says, you can only really classify the defect at the time of surgery. A baby might act like a bad baby and have a mild defect, but this is an independent factor related to both morbidity, especially length of stay, and mortality. A is the smallest defect. There's diaphragm present, 360 degrees around the defect, can be closed 100% of the time with sutures. B, 50 to 75% of the diaphragm is present, less than 50% of thoracic wall is involved. Sometimes you can get these closed with sutures, but usually we'll need a little patch laterally. C, 25% of the diaphragm is present, greater than 50% of the thoracic wall is involved. And then D is what we call diaphragmatic agenesis. where there's really nothing. And those are the most challenging to repair. Definitely have to repair C and D with mesh. There's usually a little furled up piece of diaphragm in the retroperitoneum that you can mobilize, but sometimes you're just sewing to retroperitoneum. The frequency of the defects, you can see there, A, 13%, B, 43.7, C, 30.2. So most of the defects are going to be in that sort of moderate size range. Again, it's the strongest predictor of survival, but you have to be able to see it in the operating room. CDH occurs in 1 to 2 per 10,000 live births, so about half as common as a lot of the more common defects like anorectal malformation, tracheoesophageal fistula. The pregnancy incidence is underestimated because there's a hidden mortality that really started to understand once the group in San Francisco in like the 80s really started looking into this. About up to 1/3 of the babies are stillborn. There's some association with the trisomies, trisomy 13, 18, and 21. 10% will have a major cardiac defect, and they're mostly sporadic. So the major contributors to what we see, the way that these babies behave postnatally, are pulmonary hypoplasia, small lungs, pulmonary hypertension, just a lot of strain on the right heart, ventricular dysfunction, and the compressive effect of the herniated valve. And let's see. This is not the one. Okay. And this is just a postnatal X-ray here. You can see, heart shifted over to the right, and this is just a thorax full of bowel gas. So let's talk about the pulmonary hypoplasia and hypertension. The pathogenesis, why do we have a small lung on that side? Well, maybe it just can't grow to expand into that thoracic cavity because there's bowel there, maybe. But maybe there's something that goes on with that lung from a sort of genetic standpoint that that both creates a small lung and a hole in the diaphragm. We don't know. We do know that there's decreased lung weight. There's decreased number of bronchioles, bronchial cross-sectional area, alveolar count and volume. There's marked pulmonary vascular abnormalities. There's decreased vascularity, prominent remodeling. So there's increased muscularization and thickness and abnormal vasoreactivity. These kiddos, you can actually see, they'll be super stable, and then the littlest thing will throw them into a pulmonary hypertension crisis. I mean, I'm talking about like turning on a light, touching them. We had babies go into pulmonary hypertensive crisis, getting a sponge bath by a nurse who's trying to be good, but ended up, flipping them over and like requiring ECMO. So very abnormal pulmonary vasoreactivity. The thing that argues for a common pathway and argues that we don't really know what's going on is that all of these changes to a lesser degree are also found in the quote normal lung. So it can't all be just because of compression from viscera occupying space in the left chest. 39% of babies will have some ventricular dysfunction. We don't really know why left ventricular dysfunction would happen other than some negative feedback that we'll get to. Maybe it's from cardiac compression and development. We don't really know. Right ventricular dysfunction occurs in some of these babies as there's a transition from fetal circulation with that abnormal vasculature. You're supposed to transition from a high pressure right-sided system to a low pressure right-sided system, and that just doesn't really happen. So there's super normal workload, and that causes some stun. Sometimes it can recover on follow-up echoes, And then, of course, you've got a sick baby who's having a lot of trouble oxygenating, a lot of trouble with distal perfusion, and the systemic hypoxia and acidosis that can be found in these babies is a negative feedback loop on any sort of propensity for ventricular dysfunction. A postnatal echo within first 6 hours of life that demonstrates ventricular dysfunction is a strong independent determinant of postnatal outcome. So single ventricle dysfunction, less so than biventricular dysfunction. So patients with biventricular dysfunction will do much worse than babies with single ventricle dysfunction, and then they will do much worse than babies without ventricular dysfunction. So fetal assessment, routine prenatal care will detect the vast majority of these defects nowadays. So, you get your anatomy scan, most people around 20 weeks, but usually it's diagnosed less than 25 weeks of gestational age. Polyhydramnios is a common finding that goes along with diaphragm hernia. The definition is that there's viscera or liver seen at the same level as a 4-chamber view of the heart on ultrasound. The liver being up in the chest is a very strong predictor of worse outcome. We call that a liver up presentation. So, if you tell somebody they, you get called about a CDH and you go talk to the NICU doctors and you ask them about the prenatal ultrasound, commonly they'll say this is a liver up diaphragm with the next measure, an O to E LHR of blank. So that's a very common way to kind of report very succinctly the severity of the defect. The lung to head ratio, so you're actually measuring the contralateral lung, and you use an observed to expected metric. So if you have, less than 25% of your observed to expected lung, you have a 18% survival chance. That's a severe defect. Moderate sized defects are classified as an O to E of 26 to 45%, 66% survival. And then greater than 45% is 89% survival. Another metric that I didn't mention is percent predicted lung volume, and about less than 15% is severe. MRI is controversial, but you can get the same measurements, and most fetal centers will try to get an MRI. People have tried to figure out ways to keep this from being such a big train wreck when the baby's born. Okay, a guy named Mike Harrison, a pediatric surgeon out of San Francisco, started studying this, and there is a condition called congenital high airway obstruction syndrome, where you're missing your trachea, and so all the fluid that the lungs start to accumulate doesn't have any way to go out into the amniotic fluid. So these babies would die, but they were born with these huge lungs. And so he started taking things, including actually started clipping sheep lungs, fetal sheep lungs, or trachea, sorry, and noticing that he could induce lung growth by occluding the airway. So then he started placing things in the airway, like balloons, and that eventually led to human trials that demonstrated greater lung volumes with tracheal occlusion. And then this in 2021 was just published. It's probably the most talked about paper amongst pediatric surgeons nowadays. And this is a randomized trial of fetal surgery for severe left diaphragmatic hernia. They even tried open repairs to see if getting the viscera out of the chest, at 25 weeks or whatever, could, create lung growth, and no, it wouldn't. But tracheal occlusion seems to work. So there's some videos embedded in. Oh, where's the non-PDF? Go back.
Endoluminal tracheal occlusion is a minimally invasive procedure performed under local maternal anesthesia, while the fetus receives an injection with anesthetics and a muscle relaxant. Under ultrasound guidance, a trocar and cannula are inserted toward the fetal mouth. A miniature camera and endoscope are carefully advanced into the mouth of the fetus under visual and endoscopic control. With gentle pressure, the tongue is deflected and the 3 mm instrument is directed toward and beyond the epiglottis down to the vocal cords. Warmed saline water is used to advance the scope through the vocal cords. A few millimeters deeper, the catheter loaded with the balloon is advanced. The balloon is inflated and eventually detached from the catheter. The instrument is then gently withdrawn from the windpipe. All instruments are subsequently withdrawn from the uterus. The muscle of the womb will close the defect. The incision in the skin is closed with one suture. The plan is for the balloon to remain in place until 34 weeks gestation. It occludes the airways, which builds up pressure in the lung, promoting lung growth. The entire procedure is typically completed in no longer than 7 to 8 minutes.
That's garbage. It takes much longer than that. The biggest risk is preterm labor, and we're talking about survivable babies otherwise. So if you go into preterm labor at 32 weeks, the survival is very, very good nowadays. But if you've got a baby with CDH who's on the severe side, who qualified for this, who has a severe measurement, qualifies for the severe arm of this trial, and then they deliver preterm at 32 weeks, if they're that small and that premature, they may not be candidates for ECMO. So, you may have had a 40% chance of survival with ECMO, but now your baby's too small to get ECMO, and then your chance of survival is very, very low. That being said, the trial results, I'll highlight the 40 in each group, which is a pretty sizable trial for something that's 1 in 10,000. Survival to discharge was significantly greater in the fetal group, 40% versus 15%. You can see it's like 1/3 of the patients had preterm pre-labor pre-labor rupture of membranes. The other things, let's see, where's the survival without oxygen? 6 months without oxygen. You see that almost 80% of babies are still needing oxygen supplementation. Without feto, it's 8%. And then you can see that only 5% of patients needed ECMO in the fetal group versus 30% in the expectant care group. So there's some benefits. There's a lot of things out there critiquing the trial, especially I think a lot of centers are having trouble reproducing these results now the trial's over. But still, this is a big deal. And the biggest deal actually is that it is kind of forcing a regionalization of diaphragm care towards centers. So centers that offer feto usually have like multidisciplinary CDH programs. So they'll go and see, there's a moderate arm paper too. So moderate and severe defects will usually get referred to one of these centers now. And so we don't have one of these in San Antonio. So you're not likely to see a whole lot of CDH in places that aren't offering feto nowadays. Okay, so you've got a baby, you know that they've got a diaphragm hernia based on your prenatal evaluation. They come out, we'll go through some of the other kind of big time initial resuscitation maneuvers, but this is a pretty striking photograph for one of the big physical findings. Let's see, medical student in the front. What strikes you about this baby's abdomen? We'll start right here since you're closest. Yeah, it's a scaphoid abdomen, right? Completely empty. And they've got this big kind of puffed out chest. So you'll notice this baby's intubated. They've got a Repogal in place. You get your initial X-ray. You want to see, confirm your postnatal diagnosis and get your make sure that your Repogal tip is in the right position. Usually the stomach is up, and so you want to see that curve into the chest there. If it's straight or doesn't make that curve, then you need to try a little bit harder. That can be a little bit anxiety producing as well. You end up having to push through some resistance sometimes to get that done. So here are the big things that you want to make sure your team is doing. Again, nowadays, most of these babies are going to be born in a place that centralizes care of these babies. So we're seeing some volume, but no bagging. If you fill that chest with air, the baby's going to do very, very poorly. So they get intubated immediately. If the baby is preterm and still has a fetal balloon in, the balloon needs to be popped and then the baby intubated to retrieve that with rigid bronchoscope. Then you have to replace a repogal. In the NICU, things that you need to tell the NICU to get for you are a chest X-ray so that you can see ET2 position in your repogal. You need a head ultrasound just to make sure that during delivery there was no rupture of the germinal matrix, no hemorrhage, and that's a pre-ECMO evaluation. You need an echo between 4 and 6 hours of life. That gives the baby a little bit of a chance to transition from fetal circulation to kind of normal postnatal circulation. The fetal circulation can overestimate pulmonary hypertension, but you're really looking for ventricular dysfunction as well. And then a UAC and a UVC, that's a umbilical artery catheter and a umbilical vein catheter. So those are essentially big central lines. So the babies used to look really, really sick. They were hard to ventilate. So people used to just crank the vent up, and then they got the numbers to look really, really good. You're like, oh man, this is a good baby. We're just going to keep cranking, turn the dials to the right, turn it up. Baby's doing great. And then all of a sudden they would crash. That was called the honeymoon period in CDH. What we realized was that you're just able to support them until you induce lung injury, and then they crash and go on ECMO. So now we try lung protective strategies, have a little bit of a lower threshold to go on ECMO. So we start with pretty low settings, usually pressure controlled with peak pressures 22, peak of 5, rate of 40, and 100% FiO2. Your most potent pulmonary vasodilator is oxygen. So babies are doing really, really well, and the nurse is like, oh, we're doing great. Let's just crank the FiO2 down to 40%. Now we're going on ECMO. So they need to wean that really, really slow. It is a historical thing. Yeah, usually give them a trial of not needing it. It's just hard to prove benefit in that situation. The thing is that not all of them are going to die, and not all of them are going to need ECMO. Exit to ECMO or exit to airway do work in things like, especially exit to airway, things like big head and neck tumors and stuff like that. So the max PIP in most protocols that you want to generate before switching over to the oscillator is 26, and then you want to keep the rate less than 60. Otherwise, you start to stack, even with these little tiny lungs. Oscillator is controversial whether or not we should go directly on the oscillator. For babies who haven't had like a week after removal of a fetal balloon, the oscillator helps with secretion clearance, and so a lot of protocols are coming out about going directly on the oscillator after the fetal balloon. The other thing is like, we've got pulmonary hypertension, so we should go on nitric. Well, that actually doesn't do anything. There's no benefit in CDH. There was a trial called the NINOS trial, and possibly by going on nitric, there might be a higher need for ECMO and increase in mortality. The problem is there's some bias there, because babies that need ECMO would be the same babies we would want to put on nitric. So anyway. Here's a great algorithm. We're going to gloss over this a little bit, but it just kind of demonstrates the sort of permissive hypercapnia and a little bit of permissive hypoxia here. So you want to keep your pre-ductal oxygen saturation, which is going to be right arm. Okay, you guys can go think about that a little bit. Pre-ductal right arm saturation greater than 85%. The ductus is likely open, and so you're getting deoxygenated blood down the leg and stuff. So if you've got a saturation monitor on the foot, it's not really accurate measure of what the baby is actually seeing, especially from a cerebral perfusion standpoint. If you want adequate oxygen delivery, so you're gonna be checking lactates, perfusion, urine output's a little unreliable in the first 24 hours, but you're gonna be following urine output real close. You're gonna be following your base deficit. And then your PaCO2, you're gonna allow to drift up to 70 if needed, as long as your pH is greater than 7.2. If you meet all those goals and we're trucking along and we've got a good echo, maybe we see some pulmonary hypertension, our initial echo, say we're cranking along. Next day, we'll get another echo. And if the pulmonary hypertension is stable, based on a couple of different measures or better, then we can go ahead and do our operative repair. So preoperative targets, resolution of hypoxia. We really don't want to be operating with an FiO2 greater than 50%. The blood pressure needs to be normalized. Lactates need to be normal. And then again, we said we want our pulmonary hypertension stable. In the initial period, everybody will freak out. These babies may have sats as low as the 70s, but if you just turn off the lights and leave them alone, and you just check some serial gases, a lot of them will get better. But it is a little, it's a sit on the trash can for a couple hours kind of thing with these kiddos. And like you're literally protecting them from everybody who wants to walk in and mess with the baby. So you're sitting there looking at gases, drinking your coffee, telling the nurses not to give them a bath, turning off the light, making it quiet, and seeing how they do. Because if they don't do well with conventional therapy, they're going to go in ECMO. And that's not a failure. A lot of these babies just end up needing ECMO. ECMO is extracorporeal membrane oxygenation. For you guys who don't know, the main strategy in CDH is VA ECMO, meaning we take blood out of the right heart via cannulation, open cannulation of the internal jugular vein, and then we're placing it back directly to the arch with a cannula in the right common carotid. So essentially it's failure of ventilation, but circulation failure as well, like not able to keep up your blood pressure is another indication. So if we can't keep preductal sats above 80%, using those max settings that we talked about, and after trying the oscillator, optimal CDH pulmonary hypertension management, maybe you can try some milrinone, but otherwise, like I said, oxygen's really your only strategy, and just trying to keep the baby understimulated. Your mean airway pressure, especially if you flipped over the oscillator, needs to be under 15. You can calculate an oxygen index. If it's consistently over 40 for 2 to 4 hours, you really should consider going on ECMO, because you're doing more harm to the lungs than good. Inadequate oxygen delivery with metabolic acidosis, so lactate consistent greater than 5, pH less than 7.2. If your PaCO2 is greater than 70 and you've got a respiratory acidosis, and then hypotension or resistant to fluid therapy, inadequate inotropic support. It's very common for these babies to get 2 little boluses, 10 per kilo saline, and then start on a little bit of dopamine. That's fine, but if you're really starting to escalate from there, you should consider going on ECMO. So repair strategies. The open repair is the gold standard, but there are thoracoscopic options available for stable babies with small defects. The open repair is commonly performed with a left subcostal incision. It's pretty generous. Usually kind of take it across the midline to the right. You go and you reduce the viscera out of the chest. The spleen is the last thing that you'll get to that's in the chest, and you just kind of gently get a finger around that and flip it out. And then you just have to evaluate your defect size. There's commonly a little leaflet of diaphragm, even in the most severe defects, that's rolled up in the retroperitoneum, and you'll hear a lot of people saying unfurling the diaphragm. You're really just sort of uncovering it, just moving a little bit of that retroperitoneum caudad so that you have a little bit of rim to sew to. But then a lot of these patients are going to need a patch repair, and so you're really just going circumferentially around the defect with the patch. In places that you don't have diaphragm, you just suture around the rib or through the rib. These little baby ribs are pretty easy to suture through or around. But on the diaphragm side here, I've got a little schematic of the way that you throw your sutures. You're throwing your suture through pledget, diaphragm patch, and then coming back through patch. You don't need a pledget on that side, pledget, and the pledget sits on the diaphragm. You tie. I've got a picture of a bilateral here where we've put patches in, so you have two opportunities to see how you do it. You just want it to kind of billow into the chest just a little bit. The diaphragm grows, the patch obviously doesn't with time. The thoracoscopic approach is cool, but there are increased recurrences that are still being reported compared to the open. The biggest advantage identified is that these CDH babies, they're born with non-rotation. So if your bowel's in your chest and it doesn't have a chance to rotate and affix itself in the normal position, then you're by definition non-rotated. And then they get a lot of manipulation during surgery, and they're at risk for adhesive small bowel obstruction. And so there is a definite benefit in the risk of adhesive small bowel obstruction with the thoracoscopic repair. Patch versus no patch is pretty obvious. If you can't get the diaphragm to come together without a patch, you have to put a patch. And then the kind of big controversies that are definitely not uniform across centers is when to repair if a baby goes on ECMO. So you can repair early in the course on ECMO, which has very good data. There's a good study. It's retrospective, but there's some pretty sophisticated propensity matching that demonstrate early may have some benefits. And the theoretic benefits of repairing early on ECMO is that you've got a new circuit. You've got the physiologic insult of going on ECMO, and then you've got the physiologic insult of doing the surgery. They're all knocked out, and then the rest of the ECMO run can be focused on getting the baby off ECMO. And then if you're doing it late on ECMO, you're already dealing with a trashy circuit. You're anticoagulated. You give some stuff to help form some clot so that the baby doesn't bleed to death in the operating room, but then you trash the circuit even more. It doesn't make a lot of sense to me, but I'm biased because I trained at a place that did early on ECMO repairs. And then there are some people who are just like, yep, if this baby survives and gets off ECMO, we'll fix their diaphragm. And that's pretty common too. But I think the early repair on ECMO, they're still generating some more data on it. Will end up being the way that we do it. You just have to, you're anticoagulated on heparin. You set your platelet goal to 100. And then run an infusion of I'm drawing blank. It's going to come to me later, but anyway, there are things you can do to decrease the risk of bleeding. Again, this is a bilateral repair. It's just kind of cool. It's really rare. This baby was doing remarkably well. Outcomes, again, the biggest predictor of both mortality and then especially hospital stay are these defect sizes. So you can see here a couple of weeks usually in the hospital in the NICU for patients with a A-type defect. B-type defects are in the hospital for a month, C-type defects 2 months, and D-types 90 days, 3 months. And this is it's easy numbers to read, but a 3 to 6 month stay in the NICU for a family is like extremely difficult and extremely costly. So CDH is the #1 highest cost disease of any pediatric surgical disease, and I actually think it might be the costliest disease overall, based on some stuff I listened to at APSA. So the baby just kind of sits there, right? And their baby, they don't care, but it's really tough on the families. And then there's some long-term morbidity that, okay, we're high-fiving, we've got a live baby, it's great. But what are these babies going to look like after we're done using all of this modern technology to save them? So the need for long-term supplemental oxygen is real, and It's quite morbid to need supplemental oxygen, especially as a kid. Just think about that, how that affects their school days or go on family vacations and all this other stuff. So up to 75% of babies who required ECMO will be on oxygen. They'll always, and then and less than 10% without need for ECMO. They always have reactive airway disease. A lot of them have big trouble. So anytime they get respiratory infection or whatever else, it wouldn't be a big deal for a regular kid. Like these kids get really sick with just common colds and stuff. They have learning disabilities up to 50%, and 5 to 20% are unable to attend regular school for whatever reason. Again, it's complex genetics versus the environment, being in the NICU, being on ECMO, having periods of hypotension or hypoxia for prolonged amounts of time. Long-term hearing loss versus in needing hearing aid. 10% of those who were on ECMO will have long-term hearing loss, 1% without, but that's a pretty big number. 10% of babies who, CDH babies especially, is where I pulled this data from, will need some sort of hearing aid. GERD is controversial because it depends on how you define it, but in some series it's up to 75%. 10 to 20% of those will require a fundo. And if you're talking about a D diaphragm baby who has a patch that's right up to their esophageal hiatus, these fundos are not super fun to perform either. They get adhesive small bowel obstructions, and then recurrence is 5 to 50%. On ECMO repairs or patients who had ECMO have a higher recurrence rate than those that didn't have ECMO, but they also have bigger defects. And that's it. You guys have any questions about that? Yes.
What's the overall life expectancy?
I have not seen any long-term, like, so one of the problems is that we lose them to follow-up. So now there are continuity clinics. It's a hot topic for things across pediatric surgery now. It's like we've done a really bad job transitioning to adulthood and then following them into adulthood. But I haven't seen anything that suggests that they live any shorter lives than normal people. If they get out of that, and the deaths are usually early. They're usually within like the first month. Like once you get them past the first month and they're repaired and stuff, even if they're on a long-term ventilator, all that type of stuff, they usually will survive.
You're doing the technique where are you putting
yeah, cruise of the diaphragm, whatever you can find. There's usually something that you can kind of find and mobilize, but that's the hairy part. On the right side, so 10% are right-sided, and that's mostly liver up in the chest. But that medial wall of the repair, like, is the hepatic veins. So that's a little hairy too.
Is there still in the modern data that says that right side is
that's also historic. The problem with the rights is that the size is usually underestimated on prenatal evaluation. And so they come out and they're sicker than you expected them to be, and I think they might do worse from that standpoint. No, they don't. It's pretty amazing, actually. I've seen a couple of little tiny patch, and they've got some diaphragm. It doesn't work normally. Obviously, if you don't have nerves growing into the, they don't function well. But you've got the other side that does. That baby with the bilateral diaphragm, I don't know how that baby's gonna do it. There are. So one of the morbidities, about 10% of patients will have a chylus effusion. and they can be pretty difficult to treat. Um, we don't, so on ECMO, I'll leave a chest tube, but in a baby that's not on ECMO, they don't get a chest tube, and so they'll have this kind of progressive pleural effusion, and then you drain it and you test it for chyle, and it usually ends up being a chylous effusion. Same thing for TE fistulas. It's all that sort of, medial dissection. Till the chyle leak closes. It's medical management usually. They'll be on, if they're getting enteral feedings, medium chain fatty acid formulas, or just TPN for a little bit of time until the chest tube dries up. I mean, greater than 95% of them will close on their own. I have not needed on any of these congenital kids or post-operative chylous leaks. I haven't had to go fix them, but we almost fixed one at university last month in a TE fistula baby. So it's very high up.
You mentioned increased risk of like a decent small bowel obstruction for abdominal repair. Is this considered non-rotated for the thoracoscopic repair? Is there like distal volvulus or?
Doesn't seem to be. I don't know, for whatever reason, these kids with I call it, there's like associated defects or things like you've got trisomy 21 that's associated with Hirschsprung disease. I call these like consequential sort of things where you've got gastroschisis and you've got non-rotation. So this is, a consequential thing. For whatever reason, consequential non-rotation, one, they're non-rotated, not malrotated. So they're not going to have like the LADS bands and the congenital effusions that these other people have, that predisposes them for some obstruction. And then for whatever reason, they just don't seem to volvulize. You would think that the scarring that you induce with the open operation with for CDH would, tether the bowel in place and prevent it from rotating. But I haven't heard any reports of any increased risk for volvulus with thoracoscopic repair.